Good morning, Dr. Harrison. For our teaching rounds today, I've put together a clinical explainer based on the source material to walk us through a case that developed overnight on the wards. As the senior resident, I want to take a really measured clinical look at this, doing a deep dive into one of our most complex hospital-acquired infections, tracing the exact microscopic mechanisms, and using that to map out a highly precise prescribing strategy. Okay, let's dive right into it with Mr. Reyes. He's a 74-year-old guy originally admitted for community-acquired pneumonia. He's been on ceftriaxone and azithromycin for 8 days now, and honestly, he was clinically improving. But that progress hit a wall last night. On hospital day 8, he suddenly developed unexplained watery diarrhea. We're talking 6 large watery stools in the last 24 hours. He's also having crampy lower abdominal pain that gets a bit better after he goes, plus a low-grade fever. Crucially, though, there's no blood in the stool, and he hasn't been vomiting. To tackle this clinical dilemma, I've structured this explainer into 4 distinct acts. We'll start with the admission presentation, move into a microscopic pathophysiology deep dive, outline our targeted ward management and severity classification, and finally cover recurrence risk and long-term disposition. Act 1, the admission presentation. Let's get right into it. Looking at his history, we really have to keep his baseline comorbidities in mind: COPD, hypertension, and chronic kidney disease stage 3. I want to highlight something absolutely critical right off the bat. His baseline creatinine is 1.1. Let's write that number down and keep it in our back pocket. Medication-wise, we have a couple of red flags. He's on pantoprazole 40 milligrams daily, and overnight, the cross-cover resident actually added loperamide for the diarrhea. Now, on my morning exam, his temp was 38.3, heart rate 104. His blood pressure is remarkably stable at 118/70, and he doesn't look overtly toxic. Soft abdomen, diffuse lower tenderness, but no rebound, no distension, and active bowel sounds. But when we juxtapose that relatively reassuring exam with his morning labs, the story changes. He's got a brand new March leukocytosis. His white count is up to 18,400 from a totally normal baseline. And that creatinine, it bumped to 1.8. Lactate is perfectly normal at 1.4. Now, anticipating the questions you always ask on rounds, Dr. Harrison. First, why are we calling this C. diff until proven otherwise? Well, any new, unexplained watery diarrhea in a patient on a broad-spectrum antibiotic like his ceftriaxone has to be treated as C. diff. There is literally no safe antibiotic class here, and that risk hangs around for up to 10 weeks post-exposure. Second, why do we check for laxatives and tube feeds right away? Because we have to strictly rule out iatrogenic causes. Hyperosmolar tube feeds, for instance, pull massive amounts of water into the gut and perfectly mimic an infection. Mr. Reyes doesn't have a feeding tube, but that newly added loperamide, that's a massive problem. And third, why isn't this fulminant yet? Because despite those climbing labs, his stable blood pressure, lack of shock, and that soft abdomen with active bowel sounds currently keep him safely out of the fulminant danger zone. Let's move to Act 2, the pathophysiology deep dive. Before we even think about testing or prescribing, we need to know exactly what's happening inside his gut at the microscopic level. Clostridioides difficile is a gram-positive anaerobe that travels via these incredibly hardy spores. Think about this. The spore is swallowed, fecal-orally, completely shrugs off our patient's stomach acid, which is already heavily suppressed by his pantoprazole, right? And it entirely bypasses the standard alcohol gel we use on our hands. Once it hits the colon safely, it germinates into a vegetative rod. But how does it get a foothold? It's all about colonization resistance. A healthy colon is packed with dense, diverse flora that occupies essential niches and metabolizes primary bile acids into secondary bile acids. Those secondary bile acids naturally inhibit C. diff. But Mr. Reyes' 8-day run of ceftriaxone completely collapsed that intrinsic defense system. The native flora got wiped out, the niches emptied, and primary bile acids rapidly accumulated. That toxic buildup is exactly what triggered those dormant C. diff spores to germinate and take over the colonic environment. Now, looking at the actual cellular injury, it's fascinating, because C. diff itself doesn't actually invade the mucosa. Instead, these multiplying vegetative rods release highly destructive toxins. Toxin B is the far more potent one, and along with toxin A, they enter the colonocytes and enzymatically glucosylate Rho GTpases. Basically, they completely inactivate them. This causes the cell's actin cytoskeleton to physically collapse, and the tight junctions between cells just swing wide open. The result? Massive amounts of fluid and large proteins pour unchecked right into the intestinal lumen. That's our profuse watery diarrhea. And the body's response to this severe toxin-mediated injury is a massive inflammatory cascade. Neutrophils absolutely flood the necrosing mucosal surface, trying to contain the damage. As the crypt epithelium rapidly dies off, those swarming neutrophils mix with fibrin, mucin, and cellular debris to form those classic yellow adherent plaques. We know them as pseudomembranes. Just a quick reminder for the team, it's not a true membrane, but a thick inflammatory exudate that is permanently stuck to his damaged colonic surface. Understanding that deep molecular mechanism forces us to define his exact clinical state. Is this a true C. diff infection, or is it just colonization combined with run-of-the-mill antibiotic-associated diarrhea? To call it a true infection, we need both the organism present and a highly compatible clinical syndrome, which in this case is his acute watery colitis. This is a crucial takeaway that I want to emphasize. Fully 20% of hospitalized patients on antibiotics are asymptomatically colonized with C. diff. 20%. They are simply carriers. They harbor the vegetative rod but don't have that devastating toxin-mediated cascade. And we absolutely should not treat them. Compare that to under 3% in healthy adults in the community. If we reflexively test patients without active liquid diarrhea, we will inevitably end up treating carriers, exposing them to unnecessary antimicrobials and wrecking whatever recovering gut flora they have left. Since Mr. Reyes does have that highly compatible clinical syndrome, we sent his liquid stool for the two-step diagnostic algorithm. Step 1, we pair the highly sensitive GDH antigen test, which detects the organism but is blind to toxin production, with the highly specific stool toxin immunoassay. If those two disagree, we move to step 2, the PCR as our tiebreaker. For Mr. Reyes, his GDH was positive, but the toxin immunoassay was negative. Classic discordance. So we ran the PCR and it came back positive. Now, we all know PCR is often a trap on the wards because it only detects the toxin gene and turns positive in asymptomatic carriers. But we have to look at this in strict clinical context. Because of his acute watery colitis and systemic signs, we aren't just treating a carrier here. We can definitively commit to the diagnosis of active C. diff infection. Which brings us to Act 3, assessment, plan, and ward management. With the active infection confirmed, we have to strictly classify his severity. This is absolutely not just an academic exercise. This exact classification dictates our ward management, drug choice, and dosing strategy. Here are the strict thresholds we use for every case. Non-severe disease requires a WBC under 15,000 and a serum creatinine strictly under 1.5. Severe disease crosses either of those marks, WBC over 15,000 or creatinine over 1.5, or involves more than 10 stools a day. Fulminant disease, however, is a purely clinical diagnosis. It ignores the lab cutoffs entirely and requires profound systemic decompensation. We're talking hypotension, shock, an ICU-level state, ileus, or toxic megacolon. So, where does Mr. Reyes fall? His WBC is 18,400 and his creatinine is 1.8. Remember that 1.1 baseline we noted earlier? Because this is an acute jump from 1.1, he squarely meets the criteria for severe infection. But crucially, because his blood pressure is perfectly stable at 118/70 and he has active bowel sounds without megacolon, he is not fulminant. That distinction is everything, fundamentally dictating our exact drug choice and route. Before I write a single prescription for this severe infection, we need to make 3 critical stops. First, halt the ceftriaxone immediately. His pneumonia course is basically done, and continuing it just fuels the fire. Second, instantly stop that loperamide the cross-cover team gave him. Antimotility agents trap the deadly toxin right intimately against the mucosa, maximizing cellular necrosis and heavily precipitating megacolon. Third, if you were on cholestyramine, we'd hold it because it binds to and completely neutralizes oral vancomycin in the gut. With those stopped, my plan is to start Fidaxomicin, 200 milligrams by mouth, twice daily for 10 days. We prefer Fidaxomicin for both non-severe and severe cases because it's a narrow-spectrum agent that aggressively targets C. diff while heavily sparing the surrounding flora, which significantly lowers recurrence rates. If the formulary blocks it for cost, oral vancomycin at 125 milligrams 4 times daily is a fully acceptable alternative. Now, we have to carefully consider what we do if things escalated on the floor. If he suddenly develops a new ileus, peritonitis, shock, a rapidly rising white count or lactate, or if a plain film shows a dilated transverse colon of 6 centimeters or more, he crosses into fulminant disease. In that disastrous scenario, standard Fidaxomicin is out. We would aggressively shift to oral vancomycin at a massive 500 milligram dose 4 times daily, plus IV metronidazole 500 milligrams every 8 hours. And crucially, if he has an ileus, oral drugs simply won't reach the distal colon, so we'd have to add a vancomycin an enema to make sure the medication directly coats the mucosa. We would also be on the phone for an urgent surgery consult for a possible subtotal colectomy or diverting ileostomy. Thankfully, Mr. Reyes is not there yet. We'll monitor him clinically on the wards. If he did end up needing more antibiotics for his pneumonia, we'd continue the C. diff therapy for at least 7 days past his last dose of ceftriaxone to protect him. We also need to watch his stool output carefully, keeping this massive paradox in mind. If a sick, highly toxic C. diff patient suddenly stops having diarrhea, do not celebrate. That sudden stop is dangerous colonic atony and an impending megacolon, not recovery. Also, once he finishes treatment, we will never, ever send a test of cure stool sample. Carriage persists for weeks, and retesting just tricks the clinical team into erroneously treating colonization. Finally, let's move into Act 4, recurrence, disposition, and teaching pearls. We have to look ahead and anticipate the future for Mr. Reyes. After his 10-day course, there is a 15 to 30% chance this comes back, usually within 2 weeks of stopping therapy. Why is that rate so devastatingly high? Because our antibiotics perfectly kill the vegetative rods, but they do absolutely nothing to the dormant spores scattered throughout his gut. Those resilient spores just wait out the storm and germinate as soon as the antibiotics are withdrawn, usually before his native colonization resistance has had time to rebuild. So if he calls the clinic in 3 weeks with watery stools again, we have a clear, stepwise strategy. For a first recurrence, our move is to switch agents and use a longer course. Say we used Fidaxomicin first, we might switch to vancomycin, specifically dosed at 125 milligrams orally every 6 hours for a prolonged 10 to 14 days. We'd also strongly consider adding bezlotoxumab. That's a 10 milligram per kilogram IV dose given once during the antibiotic course, never instead of it, that binds and neutralizes toxin B to prevent future recurrences. We just have to use caution if he had congestive heart failure. For second or third recurrences down the line, we're talking a pulse taper vancomycin regimen, getting infectious diseases involved, and eventually referring for a fecal microbiota transplant after a third episode to directly restore that missing colonic community. To close out my presentation for rounds, I want to cement 4 core teaching pearls for the team. 1. Never treat a positive PCR without a compatible colitis picture. You're just treating colonization and doing more harm. 2. Remember the paradox. Sudden diarrhea cessation in a sick patient is colonic atony, not recovery. 3. Always hunt down the baseline creatinine before confidently classifying a case as severe. A 1.8 creatinine means nothing if their baseline is 1.8, but for Mr. Reyes, it was an acute jump. And 4. When it comes to contact precautions, alcohol-based gels are absolutely useless against C. diff spores. You have to strictly use soap and water. Concluding this case, Dr. Harrison, I'll leave the entire rounding team with this final thought to reflect on. Knowing exactly how efficiently our broad-spectrum antibiotics collapse a patient's intrinsic colonic defenses, and how that allows primary bile acids to trigger this devastating cascade of toxin-mediated necrosis, how will this change your own reflexive antibiotic prescribing and stewardship practices on the wards tomorrow? Thank you.